I'm presenting an interesting case of a post-CABG patient who presented to us. She was a 70-year female, known case of old ACS, had a CABG in 2012 at some other center, and she presented with resting chest pain for past 3-4 days. The enzymes were positive. On examinations, she was hemodynamically stable. The ECG showed QR in inferior leads. The EF was 41%. So a diagnosis of post-CABG, acute coronary syndrome, non-ST elevation MI was made and angiogram was done. In the native vessels, the circ and RCA were chronic totally occluded and LAD was critically diffusely diseased, for which CABG was done. On graft angio, the grafts were, all the 3 grafts were patent, that is RSVG to distal PDA, Lima to LAD and OM. But what could we see was this lesion in the PDA, which was seen filling retrogradely from the insertion of the graft. And the PLV was also supplied by this retrograde flow, and this PLV was also subtending a large myocardium. So the issues was that the culprit was the lesion of PDA. Antegrade access via native RCA was not very easy. PCI via graft into the native RCA was the only option that we saw that time. The lesion was tortuous. There were 3 bends to cross through. Guiding support was essential and proper wire was to be selected. Again, passage of balloon and stent was bit dicey. Thrombus presence was always an issue in a post-CABG lesion. So we plan to have a femoral access 6 French, guiding Judkins right 6 French with capacity of deep throating without pressure damping, which was checked beforehand in the angio. Wire chosen was Cougar XT with soft tip but with strength. That was to be parked in PLV across the lesion of PDA for adequate distal support. The pre-dilation was planned at low pressure, and if a stent was not possible, then drug-eluting balloon could have been a choice. And in the choice of a stent, it should have good trackability and short length. And the wiring was not of much difficulty. We crossed the wire and parked in the PLV. Pre-dilation was done with 2x10 mm semi-compliant balloon. Drug-eluting stent was placed and inflated. And after inflation, the shot showed a concertina effect. Then we pulled back the wire and took the final shot, and it was good. So the take-home message is that PCI through graft into a native vessel is a viable option. PCI per se in the graft is difficult and not very good results, but yes, we can use them as slaves. So choose wisely, plan before, be gentle, slow but sure.